the clinical appearance of a patient with heart failure, as we can see right here, includes, first of all, respiratory manifestations such as shortness of breath and breathlessness, orthopnea, and finally, paroxysmal nocturnal dyspnea, which happens when the patient is sleeping and suddenly wakes up battling to take a breath. Of course, the heart is connected to the lungs. This is why the first clinical symptoms are respiratory. Now, as a general clinical appearance, we have reduced exercise tolerance, as well as fatigue, and the feeling of tiredness. Of course, heart failure, and more specifically congestive heart failure, will lead to ankle swelling. We're going to have the clinical picture of ankle edemas. Now, in addition to that, we're going to have increased jugular venous pressure and jugular vein distension, again due to congestive heart failure, as well as the so-called hepatojugular reflux. When we palpate the liver, this will increase the venous pressure, jugular venous distension due to the liver palpation. Finally, we're going to have a third heart sound, so the presence of S3 and S4. The difference between these two is that S3 indicates a advanced heart failure. It is a proto-diastolic sound, where the S4 is late diastolic and indicates a decrease of the ventricular compliance. So remember, S3 proto-diastolic, so in the beginning of the diastole, and indicates advanced heart failure. S4 in the late diastolic, so the end of the diastole, because it is 4, right? It is after 3. It indicates a decreased ventricular compliance. Finally, in heart failure, we have a laterally displaced apical pulse. So the apex of the heart isn't palpated the fifth intercostal space mid-clavicularly. It is palpated a bit more laterally. This happens due to the cardiac remodeling from heart failure. Right here is the normal heart. Then heart failure is a condition characterized by symptoms, for example, shortness of breath, edemas, fatigue, accompanied by signs such as increased jugular venous pressure, for example, or pulmonary crackles, caused by a structural or a functional cardiac abnormality. This condition of heart failure almost always causes a reduced cardiac output, as well as elevated intracardiac pressures. So these are the two major results of heart failure. Now, HF, REF is the first type of heart failure, and it stands for heart failure with reduced ejection fraction. We say that the patient has heart failure with reduced ejection fraction when has a significant decrease of the left ventricular systolic function. When he has a decrease in the left ventricular systolic function, it means that we're going to have a reduced left ventricular ejection fraction. So we diagnose it when the left ventricular ejection fraction is less than 40, when the normal is 60%. Again, patients with decreased left ventricular systolic function with left ventricular ejection fraction less than 40% have heart failure with reduced ejection fraction. The second type of heart failure that we have is HF, MREF, which stands for, again, heart failure, this time with mildly reduced ejection fraction. As the name suggests, in this type of heart failure, we've got a mildly reduced left ventricular systolic function, translates again into a decreased left ventricular ejection fraction, this time between 41 to 49%. Again, this is not very decreased, such as heart failure REF, it is mildly decreased. So this was the second type of heart failure with mildly reduced ejection fraction. Finally, there is another clinical condition of heart failure where we have all the symptoms of heart failure as well as the signs of heart failure, in addition to structural or functional anomalies on the heart, in addition to perhaps increased natriuretic peptides. In contrast to all of these, the left ventricular ejection fraction is more than 50%, so it's close to normal. This condition right here, where we have a preserved left ventricular ejection fraction despite all the symptoms, signs, and structural anomalies of the heart, is called heart failure with preserved ejection fraction. So HFPEF. So the three types of heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, and heart failure with preserved ejection fraction. What are the risk factors of heart failure? Of course, a risk factor is decreased physical activity. Smoking is, of course, another risk factor. Alcohol. Also, the infection from the influenza virus causes heart failure. Heart failure is also known to be caused by some medications, so cardiotoxic drugs. Of course, a huge risk factor in heart failure is hypertension. And finally, coronary artery disease. So these are the major risk factors for heart failure. So all of these lead to either to a diseased myocardium abnormal loading conditions, and arrhythmias. Of course, these all translate into the left ventricular diastolic dysfunction. As we said, heart failure can either be caused by the systolic dysfunction or by the diastolic dysfunction. Ejection fraction solely depends on the systolic function or dysfunction. So if we have heart failure due to systolic dysfunction, we're going to have a decreased ejection fraction. So we're either going to have what we call heart failure with reduced ejection fraction or heart failure with mildly reduced ejection fraction. We said the diastolic dysfunction doesn't play any role in the ejection fraction. So if you have heart failure due to diastolic dysfunction, we're going to have heart failure with preserved ejection fraction. Systolic dysfunction can either happen due to impaired contractility, for example due to coronary artery disease, for example by a regurgitation of a valve or a cardiomyopathy. Systolic dysfunction can also happen due to a very increased afterload. This is the pressure that the left ventricle has to exceed to pump blood from the aorta. Increased afterload can be achieved due to aortic valve stenosis. We need a big pressure to pump blood outside in the aorta, or uncontrolled hypertension, for example. So impaired contractility and a very increased afterload cause systolic dysfunction, which translates into reduced ejection fraction or mildly reduced ejection fraction. Now, an impaired diastolic dysfunction causes again heart failure, but this time with preserved ejection fraction. Diastolic dysfunction may be caused, for example, by left ventricular hypertrophy, restrictive cardiomyopathy, or for example, a pericardial tamponade. Anything that causes diastolic problems, the heart can't fill. Systolic problems, the heart can't pump blood outside. The management of heart failure is usually pharmacological firstly. It firstly involves administration of ACE inhibitors as well as angiotensin receptor blockers to decrease, of course, the vasoconstriction effects of angiotensin. Pharmacological management of heart failure also always involves the administration of beta blockers, which decrease the heart rate, meaning that they decrease the myocardial oxygen demand. We also always administer loop diuretic to decrease fluid overload symptoms. For example, shortness of breath, edemas and stuff like that. Loop diuretics also ultimately decrease the cardiac afterload, so we have less volume inside the blood. Finally, we also administer mineralocorticoid aldosterone antagonists, again antagonize aldosterone and lead to the increased sodium excretion from the urine. Just like loop diuretics, they also decrease the afterload. Of course, advanced heart failure patients are going to need a heart transplantation. Για να θυμάσαι όλο το medication to heart failure, θυμίσου το εξής. In heart failure, we have a diseased heart and we want to take it very easy on the heart. So first of all, this is why we administer beta blockers, right? To keep the heart rate down and so we don't need that much oxygen. First of all, we decrease the heart function with beta blockers and we need to take blood outside of the heart so it doesn't have to pump all that blood when it can't because it is failing. So this is why we have angiotensin receptor blockers and ACE inhibitors. These won't have to cause vasoconstriction, so we have more blood in the vessels and less in the heart. Loop diuretics will help us decrease the afterload by excreting volume and decreasing the volume inside the vessels. Again, mineralocorticoid aldosterone antagonists have the same effect. They will decrease afterload from sodium and water excretion. Another medication that we can use for heart failure are S-GLUT2 inhibitors. Now, S-GLUT2 inhibitors or sodium glucose cotransporter 2 inhibitors, they are normally used for diabetic to lower the blood sugar level. Can also be used in heart failure as diuretics. Είναι αυτά που λέμε τα glyphosines. Empagliflozin, dapagliflozin, canagliflozin, ertugliflozin. This right here is a very important graph for the management of heart failure, specifically heart failure with reduced ejection fraction. First of all, before going on with the categories, we need to know that we always administer diuretics. It's done for symptomatic relief. So firstly, we always administer diuretics. Then we start the therapy firstly with beta blockers as well as ACE inhibitors. So this is the first step in the therapy of heart failure. Beta blockers and ACE inhibitors. If the patient is still symptomatic and the left ventricular ejection fraction is less than 35%, we go ahead and move on to the second medication, which are mineralocorticoid aldosterone receptor antagonists. If the beta blockers, ACE inhibitors don't work, we move ahead with mineralocorticoid aldosterone receptor antagonists. If the patient is still symptomatic and the left ventricular ejection fraction is less than 35%, then we administer those S-GLUT2 inhibitors, the so-called gliflozins. If the left ventricular ejection fraction is still less than 35%, then we take other measures such as replace the ACE inhibitors, with angiotensin receptor blockers. We're going to need to implant a pacemaker. Administer ivabradine, which is a drug that inhibits the sinoatrial node and basically slows down the heart rate while not interfering with contractility. Now, if we have heart failure with desynchrony, meaning that we have a problem in the conduction system due to the heart failure, and the treatment options involve CRT or cardiac resynchronization therapy with the aid of a implantable pacemaker, or a ICD, also known as implantable cardioverter defibrillator. The implantable cardioverter defibrillator is used to reduce the risk of death in patients with ventricular arrhythmias. Another treatment strategy in severe heart failure, when we can't compensate it with medication or with a ICD, is of course the left ventricular assist device. Of course, we can also perform a complete heart transplantation. That was pretty much it in the treatment of heart failure, of chronic heart failure.